Hi there. Thank you for joining UnSCRIPted. I'm Angela Kashuba, Dean of the UNC Eshelman School of Pharmacy. We have an amazing community here at the school, all working toward a shared goal of solving the world's most pressing healthcare challenges. I'm excited for you to hear unscripted stories of faculty, staff, students, alums, and partners. Today, I have invited Dr. Betsey Tilson to my office for a conversation. Dr. Tilson is the North Carolina State Health Director and Chief Medical Officer for the Department of Health and Human Services. Thank you so much, Dr. Tilson, for joining me today.
Oh, thank you for the invitation. I'm excited to be here.
So can you talk about your path to public service and what that looked like for you?
Public service has really always been part of my professional path. It's where I've had that calling, even starting in medical school and residency, and up till today. I went to medical school, and my second year, I did my pediatric rotation, and my attending was also a professor at the School of Public Health. Okay. And he brought that public health and prevention aspect to pediatrics. And so I fell in love with pediatrics from the prevention standpoint and public health because of that mentor. And then my first job out of training was primary care at our local health department. So really delivering that frontline clinical care for our historically marginalized population and our more vulnerable population. So from there, I took advantage of the great opportunities that are here right at UNC, and so went to the School of Public Health, got my master's in public health and maternal and child health, as well as did a second residency in preventive medicine. And so from there, I actually went to Duke for a couple of years and did a lot of community-based research on health promotion, and then moved back to Wake County in a program called Community Care of North Carolina. And this we did in partnership with the state. So partnership with Medicaid and working with people covered by Medicaid and their primary care providers and thinking about how do we wrap a more coordinated system around those patients and then that primary medical home. So really thinking about system level and again, partners. And then that led me to the state. I've been with DHHS for 7 years now and thinking about how do we do that system level change and really think about whole person health and wrap around all of our organizations and our systems in service of that whole person.
So I love this concept of a whole person health. Can you unpack that a little more and talk about what all of the components of whole person health are?
Yeah, and I use those words intentionally.
Okay.
Some people will say whole patient care, but I think that misses a piece. So we think about whole person because patient really defines you when you are interacting with a clinical setting, which is 1% of your time, really. Yeah. Whole person is really thinking about all those things that are impacting people's health and well-being that happens outside of those clinical walls. And a lot of times people refer to those as social drivers of health, but thinking about where do you live and your housing and food and transportation, environmental justice. There's so many things that impact a person's health. Yes. Outside of clinical care. And then health as opposed to just care. Care is a really important part of health, but as I just described, there's a lot of other things that impact your health that is outside that clinical care.
So that seems quite daunting when you take all of those individual pieces that are affecting the health of a person. So how are you approaching tackling that problem?
It is daunting, and there are so many aspects to that, and there is such a element of historical context, legacy context that have really led to a lot of the health disparities that we see now. So some of the areas that we've really focused in on is they're not really those underlying determinants of your health, but they are your unmet needs right now. Some of that is thinking about whole person care in the context of medical and behavioral health. Okay. Also thinking about that pharmacy care in there, but then also thinking about these social needs that are pretty proximal to health outcomes, thinking about food, housing, transportation, interpersonal violence. So starting with some of these very concrete, really important unmet social needs, starting to move the needle on that, and then starting to go more and more upstream to hopefully prevent people from having those unmet needs.
Yeah, interesting. So in the 7 years that you have been in this role, have you had some specific wins that you're really proud of in this space?
Yes, lots of wins. I think the biggest overall win is this concept of partnering,
Yes.
and we can talk more about that. But
Yeah.
I think that's the North Carolina DNA, that we
Yeah.
work across partners, across institutions.
Mm.
One area that we're really excited about is through our Medicaid program, which
Okay.
allows us some flexibility of how we utilize Medicaid dollars to pay for things that weren't traditionally paid for by Medicaid. They weren't considered clinical care, and so you couldn't pay for them. So we have some flexibility in our 1115 waiver to be able to actually use Medicaid dollars to pay for food, housing, transportation, and services around interpersonal violence.
That's
amazing,
fantastic.
game-changing.
Yeah.
And so one, we had to set up this whole system that healthcare and social services were completely separated. So we had to create a delivery system, an ecosystem, a connected ecosystem to be able to deliver services. We've been able to do that, and we're delivering services very efficiently. So we partner with UNC, the Shep Center. They're our third-party evaluator, and we just got our most recent evaluation that showed, A, we're efficiently delivering services. B, we're decreasing people's social risk and needs. We're decreasing unnecessary emergency department visits.
Oh, that's terrific.
We're decreasing hospitalizations, and we're saving $85 per person per month on
that's
healthcare
amazing.
costs. It's amazing. So really addressing those things that are driving.
Right.
We are improving health, and we're saving dollars, which is so exciting.
That's a really exciting win.
Yes.
Yeah, congratulations on that. So let's talk about the partnership with the pharmacy school. The biggest connection that you have to the pharmacy school is with our regional associate dean for Western North Carolina, Dr. Molly Scott, and the work that she has partnered with you on in the area of hormonal contraception. Can you talk about the development of that partnership, how that came about, and some of the impact that you're seeing now?
We have an evolving landscape of reproductive health in this country and in this state.
Yes.
We also have a governor who is incredibly committed in really increasing and preserving access to the full suite of healthcare for women, including reproductive healthcare. In 2021, there was a law passed that expanded some of the scope of practice for pharmacists that included hormonal contraception, which we'll get back to, also nicotine replacement, prenatal vitamins, glucagon, and post-exposure prophylaxis for HIV prevention. So we started working on that in crafting a statewide standing order that was executed under my authority. And we had that in play for about a year or so, getting feedback and tweaking, making sure it was working right on the ground.
Yes.
And then once it really seemed that it was in a good place, then it was adopted as formal protocol by the medical board and the board of pharmacy. So now our pharmacists can work under this protocol from the board of pharmacy to do these expanded clinical services. So we had all that in mind, which was great. But then we also needed to figure out, how do we do that outreach to the pharmacies in the field, that A, they're aware of it, B, they could get the training, that we could troubleshoot the problems they were having. And that was the work then with Molly. She was able to go and get a philanthropic grant to help support this implementation work. And so now we work closely with her, the North Carolina Association of Pharmacy, and then our team, both Medicaid and public health team, on how do we really help support our pharmacists to adopt these protocols. And we not only enrolled our pharmacists as providers, but also have now a code that pharmacists can bill for that clinical services for a first-time patient and for a follow-up patient as well. In 2024, we have at least one pharmacy, if not more in many counties, but at least one pharmacy in 93 counties that are utilizing this protocol.
That's
more than
tremendous.
350 pharmacies. And we have an amazing website called ncpharmacyfinder.com that the North Carolina Association of Pharmacists have put up, that people can see what pharmacy in what county not only is doing birth control, but a lot of other clinical services as well. And our pharmacists, our community pharmacists, they know their communities. They know their families, and they can really help connect people into that broader system as well.
No, you're right. As I travel the state and talk to our alums who are in a community pharmacy setting, you can really feel the heart that they have for their communities. They know where the gaps are. They want to be able to fill the gaps. And they work very closely with clinicians in the areas as well. So it's interesting to hear you talk about the associations kind of coming together around this, because oftentimes we hear a lot about the politics and some of the fighting that happens up here, but when you're boots on the ground and you're talking about family practice physicians who are working with pharmacists in a really collaborative way, I mean, you see how the impact is happening in patient care. How did you manage to bring the organizations together and talk to each other and collaborate?
I think there's a collaborative environment in general, but the legislation really forced that collaboration. And so then we knew we had to write standing orders. In the legislation, it said the state health director will write a standing order. And so to do that, and we wanted a standing order that was robust enough and really the best standing order that we could do so that it would pretty easily be able to convert into a protocol. So to do that, and I think we have connections, we have relationships, we are able to pull those different organizations together. Now I won't say there wasn't some tension in there. There wasn't some things we had to hash out, but we did, and everybody knew that this was the goal, is that this is what's going to be best for the people of North Carolina, the health of North Carolinians. And once you have that focus, then we can get through some of those pressure points because we know it's serving people. Yeah,
no, that's tremendous. It's a really great, I think that's a really great example of how you can really have professions working together for the common good. I think that's wonderful. As we think about UNC Chapel Hill, and we have all of our health professions, you can see all of our buildings just outside of this front door. So pharmacy, medicine, nursing, dentistry, public health, and social work are all right here in kind of a unique arrangement. As we think about what we might be doing for the state or filling healthcare gaps in the state, are there things that we should be thinking about in terms of either training our students or training our students together on?
Well, our undergrad and our graduate schools are really one of the best in the world. We have such an incredible asset here right on this corner. It's incredible. First in class in research, in teaching. And I think what we're all thinking through also is how do we also have our public school also engage in practice, in public service and practice right here in North Carolina as well. So I'm really excited about that lens and that turn of UNC to really think about how do we do practice and what does that mean. I think our collaboration with Molly Scott is a perfect example of that, where we had this law, we had the protocols, but how do we actually implement on the ground and get our pharmacists engaged and thinking about the training and thinking about the support. That's been a critical piece, which I see our schools doing more and more of, that is actually giving that TA, that support specifically for our providers on the ground. And then collaborating, right? So this is a perfect example of pharmacy, medicine, Medicaid, public health, all working together on contraception, which I think we can do across multiple other things. So having our institutions collaborate within the walls, then with our state and local public health, and then in our communities, so people are actually doing they're walking the walk. We're not just talking the talk, but we're walking the walk. And having our students have some of that practical experience out in those communities, it can be magic.
That's wonderful. At any given time, in North Carolina, we have about 225 of our students who are in the field because our curriculum is unique in a way that it's very experiential heavy. So being able to lean in on that and thinking about linking clinical care with public health in a really intentional way, I love that. It gives us more opportunities, more things to think about for the future. Thank you so much for spending time with us today. This has been a really wonderful conversation. We appreciate your time and all that you're doing for North Carolinians, for the health of North Carolinians. So thank you.
Well, thank you. And I appreciate the partnership of everybody in the school and on faculty. It's been an amazing partnership.
Yeah,
so thank
and
you.
Lots of wonderful things for the future.
Yes.
Yeah, thank you. And thank you for watching. We love sharing stories of those who make the UNC Eshelman School of Pharmacy excellent. We hope you will join us for the next episode of UnSCRIPted, conversations with the people who are advancing medicine for life.